Thank you. Good afternoon or good morning, depending on where you're at today. Welcome to the workshop, CAR T Cell Therapy in Myeloma, What to Expect and Late Effects. My name is Michael Riato, and I will be your moderator for this workshop. It's my pleasure to introduce today's speaker, Dr. Nausheen Ahmed. Dr. Ahmed is a board-certified hematologist-oncologist at the University of Kansas Cancer Center, where she serves as the medical director of Transplant and Cellular Therapy Survivorship Program. Her primary focus is on providing expert and compassionate care to patients with blood cancers, including lymphoma and myeloma. Her research interest involves quality and process improvements, care delivery with respect to CAR T cell therapy, and increasing diversity in clinical trials. Please join me for today's workshop in welcoming Dr. Ahmed. Dr. Ahmed, go ahead.
Hello, and thank you all for having me. I will get right into it. So today's talk is about CAR T therapy in multiple myeloma. We'll go over what is CAR T therapy, who should be considered for it, what does the patient journey look like, and go over some efficacy, toxicity, and future directions. First of all, what is multiple myeloma? Multiple myeloma is a cancer of mature plasma cells, which you see over here in the picture. These are cells that live in your bone marrow. The multiple myeloma can be detected by your physician either because of abnormal blood work, maybe kidney function abnormalities, or symptoms such as bone pain, fractures, unusual fractures, confusion, or any other symptoms similarly. The treatment for a newly diagnosed patient, which we call frontline treatment, is typically a combination of chemoimmunotherapy as well as a stem cell transplant. Now, these therapies are generally not considered curative, and many patients might still end up having refractory disease or progressive disease at some point in time, which may be even years after they were initially diagnosed. And what we are going to focus on, our CAR T therapies, is one of those treatment modalities for relapsed or progressive disease. So here's just an idea. This graph just shows that the prognosis in patients who are relapsed refractory or progressive disease and who've had several lines of therapy, the survival can be, the prognosis can be poor. This is a graph by Gandhi et al. In 2019. This is before the time of CAR T therapy. So this defines that there was a need to get better therapies, and that is how we got CAR T therapies approved for patients with refractory disease. Now, just to give you an idea of what CAR T therapy means, what is it? So our T cells are the soldiers in our bodies that should help clear up all cancer cells. T cells are part of our white blood cells. They're part of our immune system, which you see here depicted in that blue cell with a blue ball. That's a nucleus. Now, these cells rely on other cells to activate them. So there's different cells involved in activating these cells, which then go and find the cancer cells. And therefore, it's a process that can easily be disruptive by the cancer cells. They can figure out a way to blind these T cells so they cannot get activated to find the cancer. What we do with CAR T therapy is we genetically modify these T cells so that now they are able to express these receptors, which you see over here. With these receptors, they pop up on the surface of these T cells, and which make them a CAR T cell. And these receptors can directly recognize the plasma cells, which are the cancer cells, and that can lead to activation of the T cell and destruction of the plasma cell. So now the T cells can independently do the whole process. It makes it a much stronger cell. Now, the next question is, how do they recognize those plasma cells? So just for your understanding, plasma cells have multiple markers on their surface that some of which may be unique to the plasma cell and some of which may be shared with other cells. There's a particular one called BCMA, which all our CAR Ts are focused right now, presently on BCMA. This marker is found on the plasma cells and hardly found on any other cells in the body, which makes it a really good target because it can allow killing of the plasma cells, which cause the myeloma, and not affect other organs or other cells. So this is our currently approved therapies all target BCMA. The therapies that are presently approved, there are two of them. There's Abecma, which is also known as Ide-cel, and then there's Carvykti, also known as Cilta-cel. If you look at the way they're engineered, they have some similarities in what we call the co-stimulatory domain, 4-1BB co-stimulatory domain. That's the way the T cells get activated. It's similar. When you look at the binding sites at how do they recognize the plasma cells, that's a similar binding site as BCMA. There are some differences in the way it's engineered to bind to the BCMA, but this is what they generally look like. So now the question is, who should consider BCMA CAR T? So at present, that's since April of 2024, it's any patient really who has progressed or relapsed after a single line of therapy should be considered for CAR T therapy. There will be some nuances about whether they have had exposure to Revlimid or whether they've had exposure to daratumumab. But that's a time when we start thinking about CAR T therapy. So this would be regardless of age, regardless of how frail they might be, regardless of comorbidities, and regardless of whether they've had BCMA therapies in the past. Because many patients might have had others like teclistamab, belantamab, they still can get CAR T. Now, I've been asked whether patients who are not fit for autologous transplant, could they get CAR T? And the answer is yes. They should at least be considered for an evaluation, even if they've not been previously fit for an autologous stem cell transplant. Given that both products are approved for patients, and this was really, until a month ago, both of these products were available only in 4 lines or later setting. The question many patients ask is, which product is best for me? Like, would it be Abecma? Would it be Carvykti? And there are many things that dictate that. Right now, it's line of therapy because now both of these are approved in earlier lines of therapy. It could be insurance coverage, availability at the center. It might be disease characteristics that your doctor would discuss with you, such as the time to manufacture, any bridging therapies, any high-risk features. There might be patient-specific factors such as risk of movement disorders, risk of toxicity, what is the fitness and comorbidities that would make one product more suitable versus another. So these are typically the factors that we think of. Just to give you an overview, like what happens. So this is a broad overview of how we get the CAR T process started. So the patient first has to go through a process of leukapheresis, which is where we collect the stem cells, sorry, not the stem cells, the T cells from the patient. This is like, this looks like, for people who are aware of what a dialysis procedure is, looks like that, where you're sitting, the patient's pretty much sitting in a chair and is attached to, there's tubings that go from your veins into a machine, and that machine is able to filter out the part that's rich in the T cells, and the rest of the blood just goes back to the patient. For some people, it's probably easier to think of a washing machine, right? You're sitting in a chair, there's a machine that looks like a washing machine, and there's tubing that goes from the patient to that machine and back. And that machine, again, filters out the part that's rich in the T cells. What happens to those cells? Those cells go to a central lab. They are genetically modified, like we discussed. They go through a whole process in the lab. The cells expand. They have to reach certain quality parameters before they're released. And that whole process can take anywhere from 4 to 8 weeks. In the meantime, the patient will just wait for those cells to get manufactured. And sometimes your doctor might recommend that you get some interim therapies to keep the myeloma controlled. Once the cells are ready, the patient will get chemotherapy. The chemotherapies in order to allow those those CAR T cells to expand in the body, and then you get the CAR T infusion. We'll go into this in a little more detail, specifically from the patient standpoint. So for the patient journey, the first step is referral to the CAR T center. Then they get a pre-CAR T evaluation to make sure that they're fit for CAR T and are good candidates for CAR T and they're appropriate for CAR T. Then they go through that leukapheresis procedure where they're hooked onto that machine that we discussed. The manufacturing procedure with possible bridging, what we call bridging therapy. That's where your doctor decides, okay, we might want to keep you on something in order for this myeloma to stay in control while we're waiting for the 4 to 8 weeks. Then the lymphodepletion, which is 3 days of chemo typically, followed by the CAR T infusion. Now, after the infusion, there's typically a 4 weeks monitoring that's done close to the center by the CAR T team. And after that, the patient can be monitored by either their referring oncologist or primary oncologist for long-term monitoring. So the first step is referral to the center. The referral, the pre-evaluation, what to expect in that. You can expect disease evaluation, so scans, PET scans, bone marrow biopsy labs. The patient can expect to get a fitness evaluation, which may include echocardiograms, cognitive function evaluation, neurological evaluation, such as an MRI, testing the spinal fluid, a frailty evaluation, interview and basic movements, as well as an onc-psych evaluation. Now, this all does not have to be done, but this is what you may expect. Also, the social workers would evaluate the social support, like is there a caregiver available for up to 30 days or 28 days, which is pretty much a prerequisite for most CAR Ts, for most centers to give CAR T. What does the insurance coverage look like? Is a financial counselor needed? And then I just put it down here, smoking cessation and other things to minimize the risk of infection and complication as indicated. The leukapheresis, we talked about this, but this gives you a better visual. This is a machine where the patient's sitting in a chair hooked onto the machine, and that machine, the blood is circulating back and forth continuously. The machine is filtering out the part that's rich in the T cells, and the rest of the blood just goes back in the patient. Now, this typically can involve like a few hours stay in the apheresis unit. It may involve using a central line. And monitoring during this time it's a monitored process. There's nurses there watching while this is happening. There could be blood pressure fluctuations, dizziness, lightheadedness, numbness, tingling, electrolyte imbalances, and the bruising tendency. But those are usually just temporary, like during the time that this is ongoing. And the nurses usually are vigilant and watch for any side effects and complications during this procedure. The bridging was the next thing while the cells are gone for manufacture. This is just therapy used to keep the disease at bay. And this may involve chemotherapy, immunotherapy, radiation, steroids. The choice really depends on like the pace of the disease as well as prior therapies used. And it's called bridging because it bridges the period between collecting the cells and delivering the cells back into the body. Then I use the term lymphodepletion. That's the chemotherapy that's given right before the CAR T. Now, the purpose of this chemo is basically to dampen the immune system so it does not try to fight the CAR T cells. It's given a few days prior to the CAR T, usually outpatient, usually it's 3 days, and the chemotherapy used is fludarabine and cyclophosphamide. And the side effects can be fatigue, blood counts can go low, there's a risk of infection. I was specifically asked about hair loss, and hair loss is not profound with the doses used in this chemo regimen or with CAR T as compared to an autologous transplant. So here's the CAR T infusion itself. The infusion is just, it can be given inpatient, it can be given outpatient, usually takes less than an hour. It's literally just like given as an IV. Potential immediate issues can be infusion reactions, but it's not very common. Monitoring is done throughout the infusion for reactions, and preferably a thick line, a central line, would be used in order to give this infusion. So now that we understand the process of how CAR T is done and administered, we will talk about the approvals in the myeloma space. Starting with 2021, when we had the first approval, which was Ide-cel, also known as Abecma, based on the KarMMa-1 study. This was the first approval of CAR T in myeloma, and we see here that it's based on an overall response rate that is 81%, with complete response rate 39% or better, which was much better than historical controls. And the overall survival, the median overall survival was 24.8 months. After that, the next year, in 2022, we had the approval of Cilta-cel, also known as Carvykti, based on the CARTITUDE-1 trial. And here you see that the overall response rates are 98%, with 83% being complete responses or better. The 18-month overall survival was 81%. A median progression-free survival and overall survival were not reached. So while there's no head-to-head comparison between these two trials because the populations are slightly different, but these are just to give you an idea of the general outcome. Now, the exciting thing this year, in fact, like within the last month, was that both of these products got approved in earlier lines. So really hot off the press is that Ide-cel, which is also known as Abecma, is now approved after 2 lines of therapy based on the phase 3 trial, the KarMMa-3 trial. So the KarMMa-3 trial was a study of 381 patients who have had 2 to 4 prior lines of therapy. Such patients were randomized to either get the CAR T, Ide-cel, or to get standard of care therapy. And we see here that the overall responses with Ide-cel were far better than that of standard regimen. So the response was 71% compared to 42%. And when we look at the progression-free survival, Ide-cel had like a 13-month median progression-free survival versus 4.4 months with just the standard regimens. The other news, right on April 5th, right the very next day, was the approval of Cilta-cel Carvykti, again in earlier lines of therapy. So this was based on the CARTITUDE-4 trial, in which there were 419 patients, and they had to have 1 to 3 prior lines of therapy. All of them had to be refractory to lenalidomide. Now, those patients were taken and either they were randomized to get Cilta-cel, Carvykti, or standard of care therapy, which was a daratumumab-based therapy. And as you see again over here, the response rates were much better with Cilta-cel, 84% versus 67%. Progression-free survival was clearly superior in the Cilta-cel group as compared to the standard of care group. And based on these outcomes, the FDA approved it after 1 line of therapy in the lenalidomide refractory patients. So this is all just all very recent progress that we've had, very exciting advances. So a lot of patients wonder that that is CAR T like the right thing for them? What are the factors that would affect outcome? So I looked at several trials to try and synthesize what are the things that might be high risk and what are the things that we think about. In general, we think about disease characteristics. So there may be certain characteristics which may affect outcomes or may you know that if like that may mean that the disease has a higher risk and may not respond as well. There's still studies ongoing to look at exactly how these would affect outcome, But things to consider are the presence of extramedullary disease, such as disease outside the bone marrow, patients who have high-risk cytogenetics, those with high disease burden, such as a high percentage of plasma cells, those with high risk, the RISS3, that's a high-risk staging at diagnosis, as well as prior BCMA therapy. Like if someone has just gotten, for example, teclistamab, which is a BCMA therapy, how would they do if they got CAR T therapy? Would the responses be less than what we expect or not? So we're still looking at that data. Other things are that might be associated with slightly lower, slightly inferior outcomes might be low physical status, so performance status of 2. That means that their patients are not very fit, not very active, and younger patients, those that are less than 70. The question comes up about comorbidities, such as cytopenias, those with like low blood counts, renal impairment, poor performance status. Their studies have shown that they may have higher toxicity, but again, some studies have shown similar efficacy. As far as frailty, which means taking into account age, performance status, and comorbidity index, so there was a paper published showing similar toxicity and outcomes being similar. Okay. Now, when I wanted to give you all an idea of what the toxicities are that we look at and how do we follow for toxicities. So I'm just outlining some general toxicities that we look at over here, with the first being CRS, cytokine release syndrome, and we'll talk about this in more detail. Then immune effector cell therapy-associated neurotoxicity syndrome, ICANS, and some others, such as cytopenias, non-ICANS neurotoxicity, that's like motor disorders due to this CAR T, infections, second primary malignancies, B-cell aplasia, and macrophage activating syndrome. We'll talk about the major ones. Firstly, CRS. So CRS is caused by a cytokine storm. What happens when these CAR T get activated is that they just rev up the immune system. It causes like a hyperinflammatory state, and that can lead to the patient having a fever, may experience low blood pressure, low oxygen levels, depending on the severity. And this is typically treated with some special medications, such as tocilizumab and other medicines that can dampen the cytokine storm. They can reduce the amount of cytokines. Just to give you an idea, based on the KarMMa-1 and the CARTITUDE-1 data here, I've shown you like most patients receiving Ide-cel, Abecma, or Cilta-cel, which is Carvykti, most of them will experience some degree of cytokine release syndrome. Grade 3 or more, which means high grade, which means pretty serious cytokine release syndrome, that's like around 5% or less. Now, neurotoxicity, what I just called ICANS, immune effector cell associated neurotoxicity syndrome, that it can be a change in mental status. Again, because of all that inflammatory response and all those cytokines that are generated by the CAR T. For the patient, that might mean that they could be confused, they may be slower to answer questions. We ask questions, we ask the patient to count backwards or count from 10 backwards. They might not be able to do that. It might be more serious, and it could be a seizure, it could be coma. So it really depends on the severity. It could be very subtle, but it could be all the way where, there's coma, patients are in the ICU. There's also an entity which is neurotoxicity, but it's not really ICANS. And that has been seen with Carvykti. There's some incidence of that. It's movement disorders. It's like Parkinsonism. So again, based on the studies, the KarMMa-1 and the CARTITUDE-1 studies, we see that any degree of neurotoxicity can be in close to 20% of the patients, but severe is just 2 or 3%. Non-ICANS neurotoxicity is described with Carvykti. That's around 12% of patients. And again, just symptom management with that. Otherwise, for ICANS, so we have to sometimes treat with steroids and other medications to help, depending on how severe it is. Prolonged low blood count, which is called like prolonged cytopenia, is another side effect of CAR T therapy, and it basically it's beyond 90 days. Can be seen in approximately a third of all patients, which means that there's low red blood cell count, low white blood cell count, low platelet count. That could mean an increased risk of infection. It can also mean that there may be more need for transfusion over a longer period of time. The treatments for this include supportive care, or just giving transfusions, giving growth factors. Growth factors such as L-thrombopag, other thrombopoietic agonists. And when available, stem cell boosts also can be helpful. There are many patients with myeloma, when they first are evaluated for a transplant, they get stem cells collected for 2 or more transplants. So if there's any stored stem cells from that time, they might be utilized at this time. Again, giving you an idea of infections and prolonged cytopenias with both Abecma and Carvykti. We see at 1 month with Abecma, high-grade neutropenia was seen in around 52 patients, as around half of the patients, and grade 3 or higher thrombocytopenia, that's high-grade thrombocytopenia, was also seen in a fair number of patients. Infections, like any grade infections, was seen in 69% of patients, but really high-grade infections was in a fourth of the patients that got Abecma. With Carvykti, around 30% of the patients did have a high-grade neutropenia, like significant neutropenia at day 30, and 41% had significant thrombocytopenia at day 30, and then going down to day 60, 12% still had neutropenia, like significant neutropenia, and 6% had grade 3 or higher thrombocytopenia. Again, infections, any grade and high grade was similar for Carvykti. So what type of infections are we looking at? Infections, this is a depiction of just general CAR T. This is not restricted just BCMA CAR T like the ones that Abecma and Carvykti are. So we see, if you look down, you see day 0. Day 0 is the day that the cells are infused. Day -7, that's when the lymphodepletion chemo is being given. And then moving forward, we have day 14, 28, 19, and 1 year. There's a constant risk of respiratory viral infection that's there. There's also a risk of bacterial infections, more so in the first month, and then that gets less and less. In the first month, many patients have neutropenia, a low white blood cell count, and that increases the risk of bacterial infections. Other things such as fungal infection, there's a risk initially, and then later on that risk decreases. PJP infection, that's a particular kind of pneumonia, pneumocystis pneumonia, that's seen in patients that have a low immune system. We typically give our patients some medicines to prevent these, such as like acyclovir for some of the viral infections, as well as PJP prevention. Many people would be on Bactrim or other similar agents. There's also, the acyclovir is for basically to affect the other viral, not the respiratory viral, but other virals such as herpes virus, HSV, VZV, which is highlighted here in the yellow. Risk factors with myeloma, the risk of infection is higher than lymphoma, which is a different disease altogether, with still being treated with CAR T. Risk factors can be prior therapies, low white blood cell counts, even at the start of CAR T. Use of steroids, if there's a complication. If there's a complication, steroids are used. If there was ICANS, that can increase the risk of certain infections. So monitoring, it's pretty structured. In the first 4 weeks, the patients have to be close to the treatment center. The exact distance may vary from center to center. There's no driving from the day that the CAR T is infused until 8 weeks post-infusion. All patients are required to have a 24/7 caregiver if their patient's not in the hospital. And the caregiver can help with driving the patient, helping managing medicines and activities of daily living, and most importantly, to monitor and report any issues, for example, confusion or change in mental status. So report that immediately, call the treatment center. The early monitoring period can be inpatient or outpatient. Some centers have a dedicated number of days of inpatient stay. I would say most centers do, and then there's the outpatient after that. Visits, if not in the hospital, are daily initially, and then they're spaced out after 2 weeks typically. What is done during the visits? There's monitoring for cytokine release and neurotoxicity, so checking the vitals, asking the questions about that would check for neurotoxicity, checking labs to see how are we doing with the blood counts, use of growth factors, transfusions, TPO agonists, which help support blood counts as needed. And then prevention and prompt treatment of neutropenic infections and other infections. Hospitalization may be required if there is fever, because fever could be from a number of reasons, such as a cytokine release syndrome. It could be infection, and rarely it's what we call hemophagocytic syndrome, which is a hyperinflammation of the immune system that needs some even more specialized treatments. It can also be required if the patient has altered mental status, which could mean neurotoxicity, amongst other things as well. Now, what happens beyond 4 weeks? So ongoing monitoring for late effects beyond 4 weeks, what to expect. There is myeloma disease assessment, which is typically done at the 4-week mark, the 3-month mark, 6-month mark, and 12-month mark. Most patients, if they do live far away from the treating center, are able to go back home after 4 weeks. We still advise no driving for that total of 8 weeks from the day the CAR T was given. One might expect their own local oncologist or to get several labs and visits done, which could be, the frequency would be determined based on how the blood counts are doing, how is the patient recovered from the CAR T. So the purpose of the visit is to monitor the blood counts and organ function, which can be monthly or more frequent if there's any abnormalities. Monitor the myeloma markers monthly, or it could be spaced out depending on how the markers are doing. And then clinically, see what's going on. Is there fever? Are there any new symptoms? Is there any movement disorder? If there are low blood counts, they may require supportive care transfusions, TPO agonists, stem cell boosts. And for infection prevention, we do continue, as I said, the antimicrobials to prevent infections for at least 6 months. Your doctor will be checking labs such as CD4 levels, which are a marker of how the immune system is recovering. And some of these medicines will be stopped based on that CD4 level as long as it's recovering. Typically, a CD4 level of more than 200 is what we look for. And also time since infusion. Now, immunizations are also done, usually starting from the 6-month mark. Patients start getting their baby shots because the CAR T really reboots the whole immune system. So if there are responses to prior immunizations, the body would have probably forgotten them. So re-immunization starting at 6 months and going up to 2 years. Certain immunizations such as influenza and COVID shots may be even earlier. So the next thing that I wanted to spend a little time on was second primary malignancies. There have been a lot of questions about this. And I would just like to share some data which Sidana presented at ASH 2023 on Abecma, just to give us an idea of what we see. Now, this was a study from the CIDMTR registry of 821 patients with a median of 11 months follow-up. And out of all, and there were 33 patients who had second primary malignancies. Out of these, the most common was skin cancer, was the basal cell or squamous cell skin cancer. Then there were cases of myelodysplasia and acute myeloid leukemia. And then there was other cases as well, such as malignant melanoma, breast cancer, CNS, and geomalignancy. The FDA did announce in November 2023, it alerted us about the risk of T-cell malignancy with CAR T therapy. So there were reports that looked into that specifically as well. There's this big study that looked at the incidence of malignancy in all patients who received CAR T, and this was our myeloma CAR T, which was BCMA CAR T, as well as the CD19 CAR T, which is used for lymphoma. They looked at this database where all adverse effects are reported, the FDA database. There were 536 such events noted. Most of them they were myeloid malignancies. So myelodysplasia, MDS, which was 38% of second primary malignancies, acute myeloid leukemia, which was 19.8% of second primary malignancies. And coming to like T-cell malignancies, there were two cases of T-cell large granulocytic lymphoma, which was like only 2 cases out of all those cases. Skin cancer was in 10%. It was 10% of second primary malignancies. When we look at a non-Hodgkin lymphoma, specifically the T-cell type, there were 17 cases. 2 of which were anaplastic large cell lymphoma from Cilta-cel. I highlighted that because that's relevant to what we are seeing. So 2 cases really, out of the hundreds and hundreds that have been treated. The FDA was, obviously is like we worried about this because it's a CAR T, and so we want to be sure that the treatment itself is not causing malignancy. So there's many reports looking into this. But so far, the incidence of T-cell malignancy is relatively like very, very, very low. I also just got out, based on the Abecma data, the CIBMTR study, which looks at all real-world patients within the United States, around 821 patients, look at the primary cause of death. And it seems that the main cause of death for patients after CAR T, if anything, is the disease itself. It's still myeloma. Other than that, there are some deaths from infection. There's around a 1% or so death from the immediate toxicities of CRS and the ICANS. And deaths from second primary malignancies around 1.7%, just to give you an idea of causes of death. Now, the next thing to talk about is where is this all headed? What are the future of CAR T therapy? And what we're excited about is the fact that other than BCMA, there are other targets that are identified that would be great targets that are found on plasma cells and not found really in on other organs as much. So good targets such as GPRC5D, which is a new target, and there's clinical trials out there using this target. And this I just highlighted here a study reported in ASH 2021 and NEJM 2022, which shows this myeloma. You see this really hot lighting up myeloma over here in the chest on the baseline, and then after treatment it's completely gone after treatment with this CAR T, which targets GPRC5D. Another advancement that we are excited about is using new platforms, trying to engineer these cells better, so perhaps using an allogeneic platform. There are trials coming around looking at allogeneic CAR T. So what is allogeneic and autologous? Autologous basically means that the cells, the T cells, come from the patient. Allogeneic means that these T cells, they come from another source. whether it's a healthy donor, whether it's a fibroblast, whether it's cord blood. So there's another source for these cells. There are several advantages of allogeneic CAR T, such as the fact that you don't have to do any of the collection process, waiting process, bridging. This is like ready, off-the-shelf available therapy. Theoretically, the T cells that come from an allogeneic source have never been exposed to chemotherapy, so would be high-quality starting material. There's an ability to standardize the product and potentially decrease production costs. There are some challenges that are still being overcome. There's many different products that are designed to overcome some of these challenges, such as the risk of graft versus host disease that come with allogeneic products. Graft versus host disease is where the cells from the third party might think that the patient's own normal cells are, shouldn't be there, and so they attack that. So that's like graft versus host disease. There's also a risk that that's the patient's body rejects those cells and doesn't allow those cells to grow. So that's like decreased persistence. So more to come on that. You'll see many clinical trials that are developing the allogeneic platform, as well as in the autologous platform, like shorter manufacturing time. Lastly, also improving access. There's when in the autologous space, like where the cells are made from the patient, there have been several challenges as these therapies rolled out in 2021. We found that there were very limited slots for the patients. The centers would get maybe between 2 to 4 slots per month to treat the patients, and there were many patients that were on a wait list. In our own center, this is a report that we got out from our center. We saw that patients that were on the wait list for a long time had worse outcomes than those that were able to get CAR T therapy. There are other reports out there of similar reports, essentially, and how patients were selected. Thankfully, that is now getting better and better. This was back in 2021. And now with having 2 products and with having more production slots, this limited slot issue is now much improved. But there's still more to do. There's, the slot limitations is getting better. There may be still geographic limitations. So in a certain state, there may be only 1 or 2 centers that are able to do CAR T. There may be some limitations by insurance for more than 1 CAR T. For example, if someone gets 1 CAR T product, insurance might not approve them getting a second product that has the same target. And there's data that, again, that we have looked at that does support that there's disparity in access based on socioeconomic strata minorities that may have less access because of barriers to CAR T. There was a question early on about global access as well. What does it look like outside the U.S.? There's a lot of room for improvement, a lot of room for growth of CAR T outside the U.S. There was a study done, a report where we talked to oncologists treating myeloma in different continents and different countries, and most of them perceived that access to CAR T was limited. In fact, we tried to see whether teclistamab, which is a bispecific targeting BCMA, might be restricted or not, and we have results out here. Some places feel that teclistamab may be more easily accessible, but in general, the theme is that there are resource limitations and there's a lot of work to be done, globally. So in summary, we went over some of the indications, who to treat, when to treat, some common toxicities, what does monitoring look like, and then future directions and areas of unmet need, including access. So I'll leave it open to questions.
All right. Thank you, Dr. Ahmed, for this incredibly great presentations. We'll now begin the question and answer session. If you have a question for Dr. Ahmed, please use the chat box on the left side of your screen to submit your question. We will answer as many questions as possible. Our first question is, and this one came up quite a lot. There's multiple questions about it. It says, can I do a CAR T therapy if I do not have a caregiver? And if I do not have a caregiver, does your facility help facilitate getting a caregiver?
That's a great question. And the answer, in very simple terms, is that a caregiver is required, is one of the requirements because of all the side effects that might happen, which we just discussed. Many facilities, will go through a rigorous process where the social workers talk to you about potential caregivers. In our own facility, most patients, when they first hear about CAR T, they haven't thought about caregivers. It comes as a surprise. We help think through who could be potential caregivers. Look at friends, sometimes church families, other people that might be helpful. And then there may be some resources. Again, this may depend on insurance and payment, but there may be some resources available. So I would encourage all patients to definitely talk to the social worker at the facility that they're being treated at or that they're being evaluated at.
Great, thank you. Next question, doctor. Can you compare the CAR T therapy compared to an autologous transplant as far as post-therapy recovery time? In other words, they want to know the difference. Does it take longer to recover from CAR T than transplant, basically?
That's a great question again. So most of my patients, in this I'm going by their experience, find that the autologous transplant may be harder initially, like physically, where there's more GI symptoms like mucositis, nausea, diarrhea, and others, which you may not see that with CAR T, right? Even hair loss, you may not see that as much with CAR T. CAR T has its own set of side effects, which patients may cruise through completely, or they may have complications, which again affect how long it takes to recover, such as that neurotoxicity or cytokine release syndrome and infection. So again, physically, if everything's going well, some people really cruise through CAR T, but there are things to think about, even in the long term with CAR T, infections in particular.
All right, thank you, doctor. Our next question. Can you have another CAR T after the first one if the first one doesn't work or fails, or you get 18 months, can you do another one?
Yes. The answer is that so if it's the same target, such as BCMA, which is Abecma and Carvykti both target BCMA, these are standard of care. If insurance allows, technically you could get it, but sometimes that in itself can be a barrier. There are CAR T trials also. Some of these trials may have more than one infusion. So please talk to your center about any CAR T trials that might be out there, because many of those trials might still take patients who've had previous CAR T. There's also CAR Ts that are coming out, as I showed, with different targets such as GPRC5D and others. So you might still be eligible for those CAR T. And all of that right now is in the context of a clinical trial.
All right. Thank you, doctor. There's lots of questions about secondary cancer, and you touched on it a little bit. And they want basically a few of the questions revolve around, is the incidence higher to get secondary cancer? Is it greater with CAR T than with a transplant?
There's no head-to-head comparison right now with CAR T and transplant. There is a risk of secondary cancers, including MDS and AML, any of those that can happen with transplant with exposure to Revlimid or lenalidomide. The duration of exposure to these lenalidomide, and then also with CAR T. I think we are learning more about this. We still have to see how it is. We need longer follow-up.
Okay. And then there's several questions about age. People want to know, is there an upper age limit? If I'm 70, can I do this? Can I not do it? There's lots of, can you talk more about the age factor in CAR T?
Oh, yeah. There is no age limit. There is no age limit for CAR T. We look at, when we do an assessment, we look at the fitness, how fit is the patient, what are the comorbidities, can the kidneys handle it, are the blood counts going to recover, what are the risks of infection, what is the baseline, what is the patient coming in with, so age by itself is not at all a barrier. In fact, one of the studies showed that patients who are above the age of 70 might respond better to CAR T, respond in terms of efficacy.
All right, thank you. Next question, doctor. How long do you have to be on IVIG infusions after CAR T? Do you get them one every 2 months? Do you have to have them at all?
I typically do recommend checking like IgG levels, and if the IgG levels are low, less than 400, which is what we use at our institution, then we want to replace with for hypogamma. We want to treat the hypogammaglobulinemia. We want to treat it with IVIG, just because there's still that risk of infection, viral infection, respiratory viral infection, non-respiratory viral infections that can possibly, the risk can be reduced if the patient, if you have that replacement. Now, the frequency of this, we check it monthly, and it can be replaced as frequently as monthly. However, if a patient is doing really well, not having any respiratory infections, you can definitely, have a discussion with the doctor to see, do you need it at all? Do you need it every 2 months? Sometimes it can be more tailored to, is there a lot of respiratory viral infections going around or not?
Okay. Next question, doctor. Are there tests to find out how many T cells remain 1 year past CAR T therapy?
That's a really good question. Yes, with CD19 CAR Ts, we have like a ViraCore that does test to see CAR T persistence. We don't typically test for this though. We do look at indirectly some B cell aplasia, which would be like low number of B cells or even plasma cells in the bone marrow to see if the CARs are persistent. But there are tests out there. There are many, the clinical trials use these tests, and they're coming out in the commercial space.
Okay, thank you. Next question. Can you talk a little bit about how effective, or is there a comparison out there or studies of how effective CAR T is concerning high-risk myeloma?
So there are studies out there showing that high-risk myeloma, which is extramedullary disease, or high-risk cytogenetics, may have a lower response rate. But again, these are some, like retrospective studies, and I'm still looking, waiting for more data in the real-world setting to get better answers on that. But right now, that wouldn't affect us using the CAR T at all.
Okay. This one's not exactly related to your presentation today, but maybe you can comment on it. A person asked, is multiple myeloma hereditary?
We typically think of multiple myeloma as environmental disease, so not necessarily hereditary. There may be rare cases of families having myeloma, but most of the time it's because of environmental exposures over lifetime, which cause these plasma cells to have changes, and then and ultimately evolve into multiple myeloma.
All right, we have time for one or two more questions. This one talks about, are there any complications if you've been heavily pre-treated, especially with Revlimid, going into CAR T therapy?
No, the basic thing with Revlimid would be if there's any cytopenias, but I mean, no, there shouldn't be because we're not using stem cells from the patient, so it wouldn't affect necessarily the collection process, so it shouldn't. No, the short answer is no.
Okay, thank you. Sorry for the chuckle there, but thank you. Next question, and this one's probably the most complicated one I see here. Lots of questions about how do you choose? How do you choose between a bispecific, transplant, CAR T? How do you make that decision?
So the field is rapidly evolving. And this, within the last in the last 4 weeks, on like April 4th and 5th, so we've had these, the CAR T jumped from being fourth line now up to first and second line. So there's going to be a lot, there may be many different ways in which we approach myeloma. So transplant, for sure, we would consider it mostly in newly diagnosed myeloma patients. There are still studies coming out there that might, later on in the future, we might challenge the role of transplant. But right now, anyone that's newly diagnosed, they get their initial induction, then they get evaluated for a transplant if they have a good response, and then go on to maintenance. So that's still all one line of therapy. How do I think of bispecifics and CAR T in the relapsed refractory setting? I would again take into account what is available, what's going on with the patient, how rapidly is the disease, what's the pace of the disease, right? What are the comorbidities? Does the patient have the support system ready, and are they ready for CAR T? Is there a slot available? So a lot of those logistic factors, as well as the disease factors that I take into account. If the disease may be progressing at a faster rate, or we cannot get a slot in time, one may want to start with bispecifics. But my inclination is whenever we can, we should try and collect for CAR T if the patient meets criteria and if the patient has a good social support system and everything in place.
All right.
These are just general, yeah. Sorry, these are just general ways that we approach this at our institution. We take in all this information and a bunch of experts, like we discuss all this, and we try to come to the best answer for the patient. And taking into account what our social worker says, what our financial counselor says, everything.
Okay. All right, doctor. Thank you so much. We are out of time for questions. On behalf of BMT Infonet and our partners, I'd like to thank Dr. Ahmed for an extremely helpful presentation and answering all those great questions. And thank you, the audience. I so appreciate those questions. It helped me. I'm a 12-year myeloma patient myself. Please contact BMT Infonet if we can help you in any other way. Enjoy the rest of the symposium and the rest of your day. Thank you very much.